Okay, well, hello everyone. My name is Sierra Stiles, and hopefully you are in the right place for our virtual forum today. So, the virtual forum is called When Behavior Tells a Story: Trauma Informed Care for Individuals with Intellectual Disabilities. I will be your moderator tonight. My name is Sierra Stiles, and then we have three lovely presenters on this topic, starting with Dr. Jennifer McLaren. So, I will introduce you to myself and then introduce you to her as well. Oh, first, some just virtual forum logistics for everyone to know. So all of the participants are going to be in a listen-only mode. If you have any technical issues or ACAP-related questions, you can use the chat box. If you have any questions for the presenters, then use the Q&A box. We do like to use that Q&A box to answer questions at the end. We'll try to address as many questions as we can as possible. Today's session is going to be recorded. It's going to be posted onto our virtual forum website within the next 24 hours. Here are the learning objectives. So we're going to discuss the prevalence and types of trauma experienced by individuals with autism and intellectual and developmental disabilities, explain how trauma may manifest differently compared to neurotypical populations, identify barriers to diagnosis and treatment, including diagnostic overshadowing, learn strategies for providing trauma-informed, person-centered care. So, introducing myself. So, like I said, my name is Sierra Stiles. I'm a graduate from class of 2020 College of Medicine at the University of Florida. I completed my adult psychiatry residency and child and adolescent fellowship at the Medical University of South Carolina. I have been a diversity leadership fellow with the APA. I'm the current vice president of the South Carolina Psychiatric Association, and I am working as a locums physician right now with interest in trauma-focused care. So that's why we bring this presentation to you. So talking about our esteemed panelists, this is our first one, Dr. Jennifer McLaren. She is an associate professor of psychiatry, pediatrics, and the Dartmouth Institute at the Geisel School of Medicine at Dartmouth. Dr. McLaren received her BA from University of Notre Dame in 2001 and her MD from Rutgers Robert Wood Johnson Medical School in 2005. She completed her residency in adult psychiatry at the Dartmouth Hitchcock Medical Center in 2008 and fellowship in child psychiatry at Dartmouth Hitchcock Medical Center in 2010. She is the section chief of child and adolescent psychiatry and oversees the behavioral and neurodevelopmental services, BANS for short, at Dartmouth Hitchcock Medical Center, a multidisciplinary group of providers who work with children, adolescents, and young adults with autism and other neurodevelopmental conditions. Dr. McLaren is the medical director of the Bureau of Developmental Services in New Hampshire and chief medical advisor for the National Center for START Services. Our next panelist is Dr. Carrie Harper. She is an associate professor and training director of the Child and Adolescent Psychiatry Fellowship in the Department of Psychiatry at Wright State University, Spoonshoft School of Medicine in Dayton, Ohio. Her professional interests includes child and adolescent psychiatry, intellectual disability psychiatry, psychotherapy, and training excellent child and adolescent psychiatrists for the future. She is employed at Dayton Children's Hospital, where she does outpatient psychiatry and works with the juvenile court system. And then our last panelist rounding out is Dr. Ilana Slav-Galayton. She is the sister of identical twin brothers with autism and the mother of a child with autism. She is also a board-certified psychiatrist who completed an autism research fellowship at Mount Sinai Medical Center in New York. Dr. Slav assisted with editing the chapter Complementary and Alternative Therapies for Autism in the Clinical Treatment Manual for Autism and has been published in the Journal of Clinical Psychiatry, Current Psychiatry, Psychiatric Times, and the Psych Congress Network. Dr. Slav-Galayton authored the book Don't Medicate, Educate: One Family, Three Cases of Autism, Safe Treatment for Dangerous Behavior. Dr. Slav-Galayton has given CME lectures internationally on autism diagnosis and management and has also lectured to families. Dr. Slav-Galayton has presented at numerous public hearings, including before the FDA. She has also spoken on New York's Capitol Press Room radio show and appeared on Your News Now, Capitol Tonight for New York. So we'll get started with our first presenter. Dr. McLaren, if you can.
Great. Well, thank you for having me. I'm going to talk about trauma exposure and intellectual disability, the risk factors, disparities, and epidemiology. So the data is really clear. that the risk of maltreatment is quite elevated in children with disabilities, and this is really remarkably consistent across studies. Children with disabilities have substantially elevated risk of trauma compared to children without disabilities. There was a systematic review and meta-analysis by Fang and colleagues back in 2022 that estimated roughly a third of children with disabilities experience some form of violence, a third of kids. And they defined violence in this study as physical, emotional, or sexual violence or neglect. They considered disability as physical, mental, intellectual, and sensory impairments and chronic diseases. In the study, they found overall that children with disabilities, that broad group, experience a rate increase of 2.08 times more trauma compared to kids without disabilities. And then when you specifically narrow it down to children with cognitive or learning disabilities, the rates increase even further to 2 to 3.32 elevation in violence compared to children without disabilities. And these elevated rates are really consistent across multiple other studies of IDD that focus on children with IDD. Next slide. So not all disabilities carry the same risk. When we think about other subtypes, right? Children with milder disabilities who are mobile and verbal, they may be particularly at risk of experiencing trauma by caregivers. As these children sometimes present as being higher functioning, and there may be a mismatch between what their parents think they can do and their true developmental abilities. And that can lead to frustration, anger, and potentially abuse at times. Children with behavioral difficulties have increased risk of physical abuse. Children with significant language impairment have increased risk of neglect and sexual abuse. And then children who have multiple caregivers that can increase exposure opportunities of abuse, but it can also be quite protective by really increasing observation and reducing caregiver burden. So there's some support in that home. Next slide. One reason that the literature can be like pretty confusing is that trauma is not a single epidemiological outcome. There are many different potential exposure domains. For studies, the outcome can be violence, adverse experiences, maltreatment, and it's not necessarily PTSD or subjective traumatic stress, right? Some of the exposure domains include physical abuse, sexual abuse, emotional, psychological abuse. It can be bullying, peer violence, neglect, maltreatment, and cyberbullying. And when we look at the studies of children with IDD, some of the studies combine all of these different exposure domains into a single outcome. And some studies also combine disabilities into one big group. And we saw that in the FANG study where they combined many different types of disabilities into one big group. They also did separate it out. And in some of the studies, the definitions and thresholds of what is considered a trauma really varies. Self-report may not be accessible in these studies. Administrative data will capture detected cases, right? But not all exposure. And I think it's important for us to really remember when we're looking at the literature that exposure is different than symptoms, right? A child can experience a traumatic event without developing PTSD, while another child may develop significant trauma related to symptoms after an event that doesn't fit into a particular administrative or exposure category. And it's important to think about that prevalence estimates describe the detected exposure under a particular definition and not truly the lifetime burden that can come along with trauma exposure. For many youth with IDD, traumatic stress reflects really the cumulative effect of many lifetime stressors. And this can be interpersonal victimization, chronic social exclusion and bullying, family stress, caregiver mental illness or domestic violence, poverty, housing instability, limited respite or support. There might be school mismatch, exclusionary discipline, restricted placements, changes in routines, or recurrent medical procedures, lots of hospitalizations, or loss of a familiar caregiver. And there's lots of caregivers and big changes with the transition into adulthood for these youth. It can be quite developmentally overwhelming, these experiences, and it can have quite a profound effect on a child, even if they don't have symptoms consistent with PTSD, and it's important for us to recognize that. There are child level factors for youth with IDD that can put them more at risk of experiencing traumas. Children with IDD may have dependence on caregivers. They might need more hands-on care that creates more opportunities for both support, but also for harm. And they might have the reduced ability to leave traumatic experiences and seek help. Some kids with IDD have a difficult time describing or sequencing or narrating events, and that can reduce disclosure and detection. Some children with IDD have aggression, impulsivity, or oppositional behavior, which may increase the caregiver stress, or those behaviors also could be a response to a traumatic experience. And then many children with IDD have social vulnerability, right? They might have a limited understanding of boundaries, consent, or coercion, and they may have a really strong desire for peer acceptance. Next slide. There are also caregiver level factors for youth with IDD that can put them more at risk of experiencing traumas. There might be high parenting and caregiving stress that we need to think about, low social support or isolation, family conflict or domestic violence, caregiver mental health or anger reactivity, and limited respite and practical supports, poverty housing or resource instability. As child and adolescent psychiatrists, it's important for us to ask about some of these caregiver stressors and put in recommendations or supports in place to help the caregivers. Next slide. There are also system and structural level factors for youth with IDD that we really need to be thinking about, where the system of care can be quite fragmented and it can be very stressful for caregivers to navigate that system of care between the school, the mental health system of care, and the developmental system of care. There's also diagnostic overshadowing, right? And this is really important to be aware of this when caring for youth with IDD, that it's important to look beyond the IDD and to look at what are the psychosocial stressors, what are some biological vulnerabilities, what else is going on in this kid's life? Do they need more of a medical workup? Have they experienced trauma? And not just see the IDD. There's more to that. And then there might be high staff turnover that's providing support for the child and family. Next slide. Well, you may be asking yourself, well, why does the trauma remain hidden? We've talked a bit about some of these, right? There can be barriers to disclosure. Some kids have those communication difficulties with limited expressive language or difficulty describing events. They might have inadequate vocabulary for anatomy, privacy, coercion, consent, and safety. Or they may really fear retaliation or disbelief or loss of an essential caregiver or service that they're accessing. They may have reliance on a caregiver who needs to maybe report, or the caregiver may lack information. Sometimes the caregiver might minimize concerns, or they may even be implicated in the exposure. You want to be cautious of some of the common diagnostic errors that can happen when caring for this patient population. So we talked about diagnostic overshadowing. It's a really important point to not just attribute new symptoms to the person's IDD. There's also behavioral reductionism when we think about that aggression or self-injury is really treated solely as challenging behavior. And you really want to think about behavior as a form of communication and look beyond the challenging behavior and look for an etiology. You don't want to have premature psychiatric closure where you don't assess for trauma and just think about anxiety, ADHD, and mood and forget to ask. Next slide. So, what the data can and cannot tell us? Well, really, what is consistent in the data is that youth with IDD experience a substantially greater burden of traumatic experiences. The disparity is observed across multiple settings and forms of victimization. For sure, the precise estimates vary across studies, and this is because the youth with IDD are frequently grouped in with other kids with disabilities. The definitions of trauma or violence or victimization might be different across the studies. The studies can vary by setting, time frame, informant, and severity or type of disability. Or the youth may have limited verbal communication, or youth who are highly marginalized in settings might often be underrepresented in some of these studies. It's important to not have trauma be an afterthought. And you want to not fall into these clinical traps where behavior is just attributed to the ID. You want to think about differences can really obscure disclosure, and that the child might have multiple caregivers and settings that fragment the history. You want to take advantage of clinical opportunities and really think about using developmentally adapted questions to the child's developmental abilities. Really get information across multiple different settings and seeking collateral information without replacing the child's voice or the history that they're giving you. You want to treat new behavioral change as a possible signal of trauma, not necessarily proof, but a possible signal, and develop a hypothesis of why that child's having behavioral change. Really, when a young person with an intellectual disability has a change from their baseline behavior, you want to think about, have we adequately assessed for trauma alongside medical, developmental, psychiatric, and environmental contributors? So, implications for child and adolescent psychiatry. We know that trauma exposure is elevated in children and adolescents with IDD. The epidemiological evidence is really compelling despite measurement limitations and underreporting. Trauma may appear as a shift in a child's baseline, may appear as a change in behavior, a change in arousal, a change in sleep, attachment, adaptive functioning, or self-injury, rather than just potentially a verbal report. You want to avoid diagnostic overshadowing. Trauma belongs in the differential for new or escalating behavioral differences. And you want to ask about trauma. We can really improve detection and formulation through developmentally informed assessment, accessible communication, thinking about trauma screening, and really having multidisciplinary coordination across the system of care. I want you to ask yourself, what should you change in your assessment process if trauma exposure were considered a routine part of your history for every youth with IDD? Thank you. I'm going to turn it over to Dr. Harper.
Hi, everyone. So thank you, Dr. McLaren. I want to talk a little bit more now about that assessment and treatment. So kind of interpreting the story we're hearing and intervening. While trauma is common in this population, it can be easy to miss. It doesn't always look like textbook PTSD, and you have to learn to interpret the language your patients speak. So let's talk about how to recognize and treat that. Dr. McLaren mentioned diagnostic overshadowing. It's a concept that's really important in this population, so I'm just going to hit it one more time a little bit. So this is when maybe a clinician sees a symptom like aggression or withdrawal and attributes the symptom to the intellectual disability itself or to a different psychiatric diagnosis like psychosis or bipolar disorder, rather than recognizing it as a trauma response. It's not a failure of intent on the clinician's part. It happens because trauma and IDD symptoms can look alike on the surface. Three things drive diagnostic overshadowing. Symptoms get misattributed to the IDD or misdiagnosed. Many of us haven't been trained in IDD-specific trauma assessment. And some clinicians even hesitate to ask about trauma history for fear of stirring up distress. And the whole system of PTSD assessment leans on self-report, and that can break down pretty quickly when a patient has limited expressive language. Next slide. So here's the practical translation. In the system cluster of intrusion and re-experiencing, instead of a patient telling you about flashbacks, you might see sudden agitation or behavior that reenacts past events. Nightmares, like in young children, might be distressing but not have recognizable content. Avoidance shows up as refusal, elopement, or resistance to a specific person, place, or care routine. Think of a patient who suddenly won't tolerate a particular staff member or going into the bathroom. Negative mood and cognition can present as withdrawal, a flattening of affect, or a regression in skills that the patient previously had. And hyperarousal, the cluster that most people already associate with agitation, often shows up as aggression, self-injurious behavior, or sleep disturbance. In fact, self-injurious behavior is one of the most frequently reported presentations of PTSD in children with severe or moderate ID. Patients I've had in this population fit these adapted criteria better. One patient pretended to sleep throughout the appointment if anything negative was brought up. Another was frequently aggressive, seemingly out of the blue. In reality, she was protecting her favorite staff member in the only way she knew how. This need to protect was rooted in her past trauma experiences. One clue to give trauma a little more thorough consideration might be treatment failure. Chronic unrecognized trauma may transform into treatment refractory mood, psychotic, behavioral, or substance use presentations. The failed treatment course, rather than a symptom checklist, might be your diagnostic indicator. Watch for patients who've been through multiple medication trials with only partial response, whose symptoms track tightly with specific people, places, or routines, or who have known or suspected history of abuse, neglect, or out-of-home placement, even if no one ever formally assessed for trauma. When you see that pattern, trauma history should go on the differential before you make your next medication change. How many of you have seen patients who have tried all the medicines, have current polypharmacy, and you just kind of cringe looking at their past and present medication list? This may be an indicator of unrecognized and untreated trauma symptoms. As you start to look for a way to assess for PTSD, first broaden criterion A of the diagnosis. As Dr. McLaren mentioned, for patients with neurodevelopmental disorders, the criterion A, the trauma, may not be exactly what the textbook says it should be or what the DSM says it should be. So we shouldn't have a strict reading of that definition for this population. Second, don't rely on self-report alone. Listed are some different instruments to assess for PTSD. Most of these, however, were only validated in adults. The DMID-2 is very useful. It's a diagnostic framework that can be applied across ages. This is where that adapted symptom list a few slides ago came from. For children and adolescents in particular, there's one instrument with direct pediatric validation, the adapted ADISC PTSD section. It's validated in children ages 6 to 18 with mild to borderline ID. It showed excellent integrator reliability and good convergent validity. It's a little bit long, but if you don't have time to maybe do the whole scale, it does have some really good questions to ask at an appropriate developmental level. Next slide. So how do we actually ask these questions? For the patient, you want to use short, concrete, direct questions and avoid abstract or hypothetical phrasing. So something like, have you ever been bullied, works better than, have you ever experienced something traumatic? When you can, use visual aids and visual timelines and allow the patient to use their preferred form of communication as well. So if that's a visual aid, writing, drawing, or communication devices, that's appropriate there. Then paraphrase and check for understanding. When talking to the caregiver, you want to ask about interactions with any caregiver who's been involved, not just the parents. Ask directly about caregiver turnover and placement history, as that's a known risk factor for trauma in itself. And ask about behavioral flags, especially if those behaviors have specific triggers. I've had several patients who always had trouble around the same time of year. For one, after a few years, I learned that spring correlated with the date of a sibling's traumatic death, and later my patient's removal from mom's custody. So it's important to ask about anniversaries and important dates. Next slide. 4 working principles for your encounter. Assume exposure and ask directly. Use caregivers as informants, not the whole story. They can add essential context, but they can miss internal symptoms. And in some cases, the caregiver may be connected to the source of harm. Remember too that trauma treatment must start with a safe environment. adapt your communication, simplified language, visual supports, and extra processing time before concluding that a symptom isn't present. The absence of a verbal report is not necessarily the absence of a symptom. And finally, treat the trauma itself, not just the behavior. A behavior plan that doesn't address the trauma may even serve to reinforce the undesired behavior. Next slide. Before we get into medication, let's talk about where treatment evidence actually exists. In a 2010 review of case-based studies of people with IDD and PTSD, indicates positive effects across modalities, including environmental change interventions, medication, and psychological treatments. Psychotherapy has the deepest evidence within that case-based literature. EMDR has case series and pilot studies spanning children through adults, including adults with severe intellectual disability. In one example, there is an intensive EMDR-based family program for children with mild ID or borderline intellectual functioning and their parents, and that took the number of participants meeting full DSM-5 PTSD criteria from 24 down to 8, with no dropout and no adverse events. Medication evidence is thinner. There are isolated case reports of medication used alongside psychotherapy, for example, treating trauma-related nightmares, but no randomized controlled trials of medication for PTSD, specifically in IDD of any age. So the practical approach. We want to borrow pharmacologic choices from general population PTSD evidence, cross-check them against what we know about how those same medications perform in IDD generally from the studies of other indications. And that's what we'll talk about. This data, however, and the data for the treatment of PTSD in children and adolescents without IDD underlines the importance of a therapy referral when considering treatment. For adults, SSRIs and SNRIs are first line for PTSD, but the numbers are pretty humbling, with response rates around 60% and full remission only at about 20 to 30%. Prazosin is a first-line adjunct specifically for trauma-related nightmares and sleep disruption. And of course, we want to avoid benzodiazepines as there's no benefit for poor symptoms and they're associated with worse outcomes overall. For children and adolescents, trauma-focused CBT remains first line, and medication is reserved for inadequate response or severe symptoms. SSRIs are not approved for pediatric PTSD, and controlled trials haven't actually supported SSRIs as the first line for PTSD in kids, even though they're commonly used off-label. When medication is needed, clinical experience points to SSRIs and anti-adrenergic agents. Next slide. Since we don't have PTSD specific trials in IDD, here's what we do know about how those same medication classes perform in this population for other indications. Treat this as a tolerability and efficacy proxy, not direct evidence for trauma treatment. SSRIs have evidence for treatment of depression in adults with IDD, and they tend to be well tolerated. However, for behavioral or perseverative symptoms, SSRIs are generally not found to have benefit, and one study even showed worsening symptoms for some. There's moderate evidence from randomized controlled trials for antipsychotic augmentation for challenging behavior in ID and autism, though not trauma specific. This class is already the most prescribed medication in this population, with use ranging up to 45% in community populations and even higher in institutionalized populations. And for prazosin and the alpha-2 agonists, there's little IDD-specific efficacy data. Next slide. The 2020 AACAP parameter is actually a dedicated, purpose-built review of psychiatric treatment in children and adolescents with ID and IDD. By symptom domain, for irritability and aggression, risperidone is the best studied agent. Risperidone and aripiprazole are FDA approved for autism-related irritability in children and adolescents. For ADHD, of course, we have methylphenidate as the first line treatment and is effective in about 40% of children with IDD. For anxiety and depression, there haven't been recent studies for SSRIs. but they remain kind of the first line treatment of choice by extrapolation from older studies. For mania and psychosis, mood stabilizers and atypical antipsychotics are preferred over first-generation agents. And for sleep, melatonin has one positive randomized controlled trial in adolescents with IDD. Best practice is to target an underlying psychiatric diagnosis rather than just a behavior. Reserve behavior-targeted medication for real risk of harm or losing a placement. You want to ask about and document baseline behavior and stereotypies before starting a medication, since those can be mistaken for side effects later. Next slide. 4 practical prescribing principles. Start low and go slow. Patients with IDD are often more sensitive to side effects and may have more difficulty reporting them, so titrate cautiously and monitor closely. Watch for antipsychotic overuse. This is the most commonly used class of medication in this population, but it comes with significant potential negative effects. Polypharmacy is common and risky. Multiple concurrent psychotropics increase adverse events and drug interactions, and deprescribing is often difficult once it's started. And watch for paradoxical reactions to benzodiazepines, which are more common in this population. A quick note on deprescribing when there's polypharmacy. Patients and caregivers may have significant anxiety regarding taking away medications. Deprescribing will go more smoothly when you have a good relationship with the patient and the care team. Therapeutic alliance is important in medication management as well as therapy. Deprescribing slowly and with 1 changes at a time is typically best. It's important the care team knows how to get in touch with you if needed. Just as with prescribing, however, it may be useful to wait out an initial seeming return of symptoms without discontinuing the deprescribing that you've started. There may be some discontinuation symptoms that will subside, or there may be other factors, including anxiety, that can create sort of a nocebo effect. To close, patients with ID face more trauma exposure and likely underdiagnosed PTSD. Diagnostic overshadowing is the single biggest reason it gets missed, so ask about trauma explicitly. PTSD often shows up as behavior, such as self-injury, aggression, avoidance, and regression, not just verbal re-experiencing. Adapt your interview questions for both patients and caregivers using simple, direct language and broader definitions of criterion. And lean on tools adapted for IDD, like the DM-ID2. In IDD, psychotherapy, especially TFCBT and adapted EMDR, has real evidence behind it. Medication for PTSD specifically does not, so treat psychotherapy as first line. When medication is used, borrow your agent and dosing choice from general population PTSD evidence, then cross-check tolerability against what we know about that medication in IDD specifically. And across the board in IDD, start low, go slow, and watch for polypharmacy and medication overuse. Next slide. And these are my references. And I will turn it over to Dr. Slack-Gallatin.
Okay, thank you, and thank you for allowing me to present. I'm presenting on on managing aggression and supporting families. Next slide, please. Overview is going to be on intellectual disability, autism, trauma and diagnosis, behavioral educational interventions, parent training or support, or special needs tutoring. And some parents will feel offended if you tell them they need training, so support and tutoring could be better words to use. Family and caregiver trauma, because trauma is bilateral. Trauma, if the individual with the disability traumatizes the caregiver, then the caregiver can go into a rage and further traumatize the individual, and back and forth. Supporting siblings of individuals with intellectual disabilities and special education law. More than 90% of people, both male and female, with developmental disabilities will experience sexual abuse at some point in their lives. 49% will experience 10 or more abuse incidents. Intellectual disability is a predisposing factor to PTSD. As we said before, more behavioral presentation and a decline in functioning may be
may occur. And also events that other people may not find traumatic could be traumatic to someone with a developmental disability, such as moving residences or a bus accident. So forcing a residential placement transfer may be detrimental, such as school district residential to adult residential, or moving to an in-state placement from an out-of-state placement when the state wants to bring them back. And we need more facilities in the country where the under 21 and the over 21 population are at the same facility to minimize that. Ask the individual if they are verbal, how they felt about the traumatic event. You search for temper outbursts, sudden mood changes. We talked about aggression and self-injury, stereotype behavior, refusal to participate in activities, reduced self-care might increase. And also we talked about avoidance symptoms. And my brother, who actually resides at a Massachusetts facility, has expressed fears of going back to New York after he had a 5-month hospitalization, including surgery in New York for his repeated head banging. And when going back to New York was suggested to him, he would start talking about cemeteries. Some adults with severe intellectual disability, you could have trauma-specific reenactments, just like you do in kids. The lower the developmental level, more likelihood behavioral symptoms rather than expressive language. And the trauma-specific reenactments can be mistaken for psychotic symptoms and may be distressing and even threatening to others present. Flashbacks may appear as current experiences, distressing dreams that might occur that don't even resemble the trauma. At least 10% of individuals with ID have an autism spectrum disorder, ASD, with some ID conditions having a higher comorbidity. And stress and trauma is a risk factor for comorbidity and the worsening of core ASD symptoms. And increase in problem behaviors can be from anxiety or depression. Anxiety comorbidity is associated with more ASD symptom severity, more impairments in psychosocial functioning. You could have more displaying externalizing behavior problems when there's anxiety. Also, in ASD, depression can present as an increase in ASD symptoms, and looking at not only the symptoms, but the increased intensity. Depression itself may be a post-traumatic condition. So for many children and adolescents with ADHD and disruptive disorders, it is likely that aggression and disruptive behaviors are the clinical targets of antipsychotic treatment. However, guidelines addressing the management of aggression and disruptive disorders in children and adolescents recommend the use of psychosocial interventions before the use of antipsychotics, including children with autism. So which gets me to ABA, because some people don't have the functioning for CBT. And this began in the 50s, early 60s, looking at environmental variables that influence behavior and making manipulations to those variables to move behavior in the desired direction. And it identifies and treats socially significant behaviors. The principles that are used in behavioralism, they're used to develop techniques and treatment approaches for analyzing and changing behavior and ultimately to improve lives. And it's been shown to be effective across a wide variety of areas. Most of it, the research is in autism, but actually there's research in parent training, substance abuse treatment, dementia management, brain injury rehabilitation, occupational safety interventions, even psychosis, and intellectual disabilities. So here's one randomized control trial with a waitlist condition, and they actually found in people with intellectual disabilities, online ABA training decreased problem behaviors and parental stress and improved caregivers' self-efficacy. And there's different certifications in ABA, and I bring this up because unfortunately a lot of places that say they do ABA, they're not using certified people, or that the board certified behavior analyst, that's the BCBA, they have too many people on their caseload, and they're not going to, they can't implement effective ABA. Next slide. Visual supports, these are very useful for people, that can always see what's going to happen next, how much time, or a visual countdown to give that predictability, especially when you've had a traumatic event that was unpredictable. You want to give them back predictability. Visual schedules are good. Also first and then boards, so they know they'll get a reward or reinforcer after they initially do what they need to do. And social stories, because you can do those in advance when they're going to have a situation that might be traumatic. If they have an advance warning, that may prevent trauma. Yeah. Individuals with ASD can have impairments in processing and interpreting auditory information, and they've actually found males with autistic-like social features had enhanced visual perceptual skills, and a study using CBT, adapted for autism with a dense visual component, actually improved emotion regulation and helped with social skills and also psychopathology. Internalizing and externalizing symptoms, adaptive behaviors compared to people in the waitlist control condition. And here's a study using a social story to practice for a blood draw, using a schedule for the student, for the child with simplistic language and format, and also a visual schedule and a positive reinforcer at the end, and practice materials. And they actually found that the program was successful in 143 out of 152 people, 94.1%. So this is my daughter's visual schedule that she had at her school. And this is her communication device on her iPad that the school district funded. And I want to show you something called functional communication training. My daughter would attack me and scratch me and bite me to get her hair brushed. And what we did was we set up a system where she was able to hand me a token to get out of her hair brushing periodically, and I'd give her a break and go back to it. And so we're going to see how that's implemented on the next slide.
1, 2, 3, 4, 5. Look at me. 1, 2, 3, 4, 5. What do you say? What do you say, Talia? No, you don't eat break. But here we go. Okay.
Okay. And next slide, please. So this is my brother. He's higher functioning, and his program, what they did was they give him every hour what they call a functional communication token, and that way he can get out of work and get a reinforcer on his terms when he wants, rather than having an aggression or a self-injury. Next slide. So here's a study on functional communication training and analysis of 91 articles, 204 people, and they found that functional communication training is one of the most common and effective interventions for severe behavior problems. And my brother, actually, he's on 7 positive behavior contracts, the less than a day, the multi-day, the overnight, all different contracts. And that's how a good, effective ABA program should work. And he's on a DRO, which is a DRO is a differential reinforcement of other behavior. And you could use intervals. So he could do, every couple of hours. My daughter needed one every few minutes. And when you don't have the problem behavior, you get a reinforcer given to you. And these are the different topographies of my brother's behavior, the target, including self-injury and aggression and other more minor behaviors. Next slide, please. So as you see, ABA works for everybody. This is variable reinforcement, right? Next slide. So this is my daughter. She has a variable reinforcement for not engaging in aggression or self-injury, and she will get a token anywhere between, on the bottom, if you look at the bottom token board, anywhere between 3.5 and 6 minutes, she gets a token for not engaging in aggression and self-injury, and the top token board is acquisition. Please play.
All right, we're gonna do some talking. Look what I have over here. Say bar. Wow, let's see. Oops, sorry. Wow. Amanda. Other gummy snacks do we have? Ooh, we love how you have your hands folded. Oh, Tommy, great job! let's keep talking.
There's the green token. Okay, you can advance it. So parent training, children could have improved behavioral outcomes with lower doses of medication, and it's superior to parent education that did not include behavior management. Next slide. So mindfulness, and this is a study with over 400 people, and they actually found adding mindfulness to standard parent training was really helpful in multiple dimensions of parenting, interpersonal mindfulness in parenting, parent-youth relationship quality, youth behavior management, and parent well-being, and it boosted and even sustained some of the effect and was especially helpful to fathers compared to standard behavior training. So providing ABA, parent counseling and training, can help safely manage these behaviors and therefore decrease abuse. And okay, parents who have recently learned also of their children's intellectual disability, they often do experience trauma. So they need support. And the parents show high levels of stress, anxiety, and depression in meta-analyses and population-based studies. So this is caregiver trauma, and I want to show you an example because we got to support these caregivers. And okay.
Hello, my name is Chiquita Glasgow. I was an employee for a company that
Sorry,
individual with developmental disabilities. I was employed there for 5 years. During my time of employment, I end up getting hurt during a physical restraint from an individual. While doing this restraint, it lasted about 2 hours. In this process, I end up retaining I end up hurting my back where I damaged my sciatic nerve. I was told by the doctors that I would be on opioid medication for the remainder of my life and that I would end up having to do a surgery eventually to take a lot of the pressure off my back. I just want to make people aware of what's going on and to be conscious of the things that, employees have to face while working with individuals with developmental disabilities.
Okay. Next slide. Sorry, it was sideways. Here's another study, 99 people of siblings. And what they found was that siblings who are more involved and perceive their efficacy and coherence is higher and loneliness is lower, experience higher levels of mental well-being and lower levels of mental distress. Personal resources also meaningfully predicted siblings' adjustment and mediated the relations between involvement and well-being. So we have to be supporting siblings because siblings can get traumatized. And again, trauma is bi-directional. Also, according to federal law, a functional behavior assessment and a behavior intervention plan should be considered for any student up to the age of 21 that has a behavior that interferes with learning. Students have a right to an education and to make meaningful progress. Students are entitled to an appropriate placement, which may include intensive applied and behavior analysis and may be a private school at government expense. In the recommendations, always use needs and requires. Don't use words consider, best, would benefit from, gold standard. It will not hold up at an impartial hearing. Aversives, there's an analysis of 109 articles on positive behavior supports, and the frequency of positive behavior was suppressed by 90% in only about 1/2 of participants using positive approaches alone. Positive aversives are procedures that are arranged as consequences for undesired behaviors with the purpose of decreasing the future frequency of those behaviors. An example of that is disulfiram, right, for alcohol dependence. Aversives are effective when combined with dense positive reinforcement, and aversives without dense positive reinforcement can increase agitation. The majority of studies on aversion therapy have used skin shock. Punishment may be critical to treatment success when the variables maintaining problem behavior cannot be identified or controlled. There's 148 peer-reviewed articles and a PhD dissertation on skin shock treatment. That was actually my identical twin brothers it was on. Studies have shown that using aversives stops the needs for physical restraints. They can be deadly physical restraints. restraints as well as traumatic. There's one subject had a diagnosis of autism and moderate ID with chronic self-injury resulting in concussions, calluses, and lacerations and aggression that resulted in 340 self-injuries and 5,354 restraint episodes over 98 months. GED was added. That was the name of the skin shock for her aggressive and health dangerous and destructive and major disruptive behaviors, which was at a mean monthly rate of 1,496 behaviors over a month, over 98 months. In the 16 months after the GED intervention was introduced, the mean monthly frequency decreased to 1.87 per month, and I have the graphs. So if you see how much it went down, and this is a logarithmic graph for the behaviors. And next slide. And also, we're going to look at physical restraints. Next slide, please. And you notice the physical restraints went down to 0. Next slide. Okay, and this is another study that my brother was in, 173 individual cases between 2001 and 2019, follow-up of 15 years, 80% one or less shocks a month, overall a 97% reduction in the frequency of severe aggressive and health dangerous behaviors was observed in the first full month, and diagnoses were many diagnoses, and treatment was combined with the DRO, the differential reinforcement for positive behaviors. Next slide. And this is my brother before and after. He was having 400 to 500 health dangerous behaviors. He had surgery to close his head, as I said. Positive only treatment, it went down to 60 to 70 a month, despite all those positive behavior plans. And then with the treatment, most months he was less than 10, never more than 40, many months 0. Physical aggression, 900 to 1,000 a month. He cracked my father's tooth and he broke a teacher's nose. Positive only treatment, it went to 400 to 500 a month. Supplementary aversive, 0 to 40 a month, most months at 0. Property destruction from 80 to 90 a month. Positive only treatment, 50 to 60 a month. Supplementary aversive, 0 to 2 a month. And now he has a paid job at school, goes on trips, no medications in over 37 years, and his last shock was in 2012. Next slide. And this is his recent graphs. And as you see, most months he's at 0 for self-injury. And aggression, again, most months at 0. And if you notice, these are logarithmic. Next slide. And there's also 7 studies that describe individuals with dangerous behaviors who maintain their treatment gains after the shock devices were partially or completely faded, as was in my brother. Here's what my brother's head looked like. And here's him at Special Olympics with his twin and my mom. And this is Matthew in the community, and you can see he's a happy guy.
Cool. Or with a D, ka, D.
Okay, you could advance the slide. And this is my brother who didn't have it. He was in New York. We couldn't get him funding to Massachusetts, and he ended up on 20 medications, mostly for the behaviors of the treat side effects. This is next slide. My mother, she January 2025. This is in Taiwan at the top of Elephant Mountain. She hiked up. And this is the next slide, June. She's got glioblastoma. And I have the brother, Matthew. He's in the ABA placement. He's cried, he's sad, but he's coping well. The brother in New York who does not have ABA, this New York State does not fund it. He ended up not changing his clothes or showering for a week, not going to program. And I had to actually pay over $13,000 out of pocket already for private ABA therapy. Before I got any reimbursement from private health insurance. And it has actually, the structure and the reinforcement has gotten him to change his clothes every day and take showers and go to program at least part-time. And we're still working, but he needs that behavior plan and that structure. Next slide. Conclusions, medications are sometimes necessary for comorbid conditions, but should never be used as a replacement for an effective behavior plan. Medications need to benefit the individual, not the placement. Recommend applied behavior analysis, supervise for a BCBA at home and or at school, or if a BCBA consultation is needed. Advocate for parent training, support all caregivers, including parents, and support siblings. Nobody is hopeless and everyone can learn. And that's the end.
Well, thank you so much to our presenters. Hopefully we can all kind of come back on. And we have a few minutes. I mean, that was just wonderful. I'm so happy that we were able to watch those videos and everyone's presentation was amazing. I'm going to take a look because we do have some questions I see. Um, Someone asked, oh, but we're also answering in the chat maybe,
Oh,
but someone asked if someone with intellectual disability is sharing auditory or hallucinations or visual hallucinations, I'm guessing, would that be considered a sign of trauma? Dr. McLaren, do you want to take that one?
sure. I think if a person with IDD is experiencing auditory visual hallucinations, you want a really pretty broad differential and think about if it's trauma, think about sort of the context of when they're having those symptoms, right? So is it triggered by certain reminders like anniversaries, sensory cues, specific people? You want to think about are the experiences intrusive and reminding them of a scary event that happened to them? Um, I think if you want to think about sort of this auditory visual hallucinations, is it random or chronic and not specifically triggered? Is it more egosyntonic? Does it typically occur without dissociative type features? Is there absence of sort of external stimulus that's triggering those symptoms? And you really want to understand sort of what their baseline functioning is as well.
Perfect. And then I see another question here asking about intellectual disability and their behavioral equivalence that's due to trauma. Do you typically see a change in those behaviors after trauma? And then is there a way to distinguish those behaviors resulting from trauma from the previously occurring behaviors? Dr. Harper or Dr. Slavgalatin, I think either of you would be great to answer that.
Sure. I think there definitely can be a change in behavior after trauma. One important thing is to try to talk to somebody who really knows the baseline of the behavior. So somebody who ideally knew the patient before the trauma occurred or before the change in behavior occurred, so you can really understand what was occurring and what might have changed. And then you can assess the behavior related to the trauma if you know there's a trauma happening, if that makes sense.
Also, I want to add, at least from my brother, when we were trying to change his clothes every day, it didn't, after he got therapy, he didn't just start doing it. And he had a pattern where Saturday, I'm not changing my clothes on Saturday because I'm too close to it. And it had an autistic feature to it, which went up when my mother was sick. Um, and these are things you can look for that were they engaging in that being stuck in that behavior before before this trauma happened? Was there suddenly that they're expressing more being stuck in routines?
I agree with what you both said. I think when assessing people with IDD, as medical providers, we're always hearing about sort of what's different and what's going wrong. But it's important when caring for people with IDD to understand, like, when the patient looks well, tell me what that looks like. Really have a good understanding of that baseline. Describe it for me. When did they last appear that way? And then understand the timeline of change. And then start to really develop a hypothesis of like, why has this patient changed from the timeline and understanding that and then thinking about is it trauma? Is it medical? Is it another psychiatric disorder? But you always have to get a pretty lengthy description about what do they like to do? How do they spend their days? How do they typically communicate? Um, and what's a typical day like for them? What's typical sleep like for them? So really a good description of that baseline and that change from baseline is critical to the evaluation of somebody with IDD.
We have like a minute, and there's so many good questions in here about ABA specifically. And I'm wondering, Dr. Slavgalatin, if you're able to touch base on just some of the suggestions for talking with caregivers about ABA and some who've had bad experiences with ABA, and how do we move forward, especially with the aversives.
Yes, so that's an excellent question. So unfortunately, most places that say they do ABA really don't do an effective job. And you might have a BCBA that's supervising over 50 people, whereas that school I showed you, the BCBA only had, my daughter had the BCBA had a caseload of 6. My brother's, it's 12 to 18. And what you could tell them, just like, there's doctors who may do an incompetent job and prescribe the wrong medications or do it wrong, and that, you get people who are highly trained, and sometimes other people are better trained. And unfortunately, one of the issues with the BCBA board is that in medicine, we rotate with different supervisors in our residency training with different settings. To get a BCBA only has to rotate with one supervisor in one setting for the whole training. So unfortunately, some of them may not be qualified, and you need to get out there and find other people that are qualified to work with these severe behaviors.
Well, thank you again. Just to answer some of the final questions that I saw, it is going to be possible to get the slides to our presentation within 24 hours. This presentation will be posted, the recording, as well as with our slides. We thank you everyone for joining us tonight, and thank you so much to our lovely presenters. I feel like I've learned so much. So everyone have a great night.
Okay, thank you.
Bye-bye.
Bye-bye. Bye-bye. Thank you.
Thank you all.